Welcome back, Iowa Ideas attendees. I hope everyone's having a great start to the conference. In case you missed the opening keynote, I'm Zack, Kucharski, the executive editor with the Gazette in Cedar Rapids. And I'm your MC for what our committee jokingly calls the All Plays, the points in the conference where we get together in one space for the keynotes and the featured speakers. A couple quick reminders. First, make sure you take time to explore the virtual conference platform Whova. We've got conference discussions already active and social groups there. You can also dig into the attendee directory to connect with panelists and fellow attendees directly. Second, keep posting your big idea moments using the hashtag IowaIdeas2021. And finally, a reminder that all sessions have closed captioning access. When in the session, you can select the CC button on the bottom right of your screen. If you have trouble locating it, just notify the session's room host using the Whova chat function, and they will get you there. And now I'm pleased to introduce our first keynote speaker. Praised for transformative leadership, Kelly Garcia serves as the director of the Iowa Department of Human Services. Governor Kim Reynolds appointed Garcia to oversee the state's Health and Social Services Agency in November 2019. She was unanimously confirmed by the Iowa Senate 3 months later, in February 2020. On June 30th, 2020, it was announced that Garcia would take the role of interim director of the Iowa Department of Public Health effective August 1st. Before moving to the Hawkeye State, Kelly served in a series of executive positions at the Texas Health and Human Services Commission. Most recently, Garcia was a deputy executive commissioner at the Texas Health and Human Services Commission. In that role, she directed 40 client service programs, managing more than 700 employees and a $1.4 billion budget. She's the architect behind Texas's successful Medicaid 1115 Women's Health Waiver application, which established a landmark federal partnership with the state's Health in Texas Women's Program. Garcia also served as the second in command for HHSC's Office of Program and Services, a division that oversaw Medicaid, eligibility operations, behavioral health, intellectual and developmental disability services, women's health, veterans health, and aging services. She managed all policies and processes for the division with a staff of 35,000 people and an annual budget of $38 billion. Garcia is a graduate of the University of Texas at Austin, received her MPA at the Bush School of Government and Public Services at Texas A&M. She's married to attorney Dan Garcia, and they have 2 children. Director Garcia, welcome. It's an honor. Thank you for joining us at Iowa Ideas.
Thank you, Zach. It's a pleasure.
All right. Well, I know that you are very busy, and we've got about 30 minutes for our conversation, so I wanted to rapid fire start. And there's been a lot of concern. We're in the midst of the COVID pandemic, and there's been a lot of concern raised about healthcare worker burnout. You've got staff from 2 points of view. Both in facilities as well as with the public health staff. And I'm curious, what do you see as the challenges, and what do you think can be done to address this?
So I think, it's a complicated issue. This work was hard before the pandemic. For my team members who serve in those frontline spaces, whether that's our social workers and child welfare, as you just said, our team members who are taking care of individuals in our 6 state operated facilities, or on our public health side of folks, those who are interfacing with their communities all day, every day. The pandemic has certainly exacerbated challenges of how hard this work is. So our role right now is to really focus on 2 key areas. So resilience and mental health, right? Unpacking what has happened during the pandemic. So many of our folks, especially on that very front line, when you think about our healthcare workers, for example, they have gone through something so traumatic. And so we really need to unpack that for them, hold space for them, really working through the trauma they've experienced, and then make sure they're equipped for resilience in this next phase. And then the second part is really tackling the pipeline. We at DHS and IDPH hold a really special space in recruiting Iowans into those direct healthcare workforce jobs. So whether that's a local public health administrator, an administrator in our central office operations, or a direct care worker on the front lines, we are actively working on conversations with high schools, community colleges, universities in the state to recruit and retain individuals in those respective spaces. That's going to take a little while longer, but we're well on our way to those key conversations. And I really do expect this to be a predominant conversation led by the governor this session.
How concerned are you that you have the time for some of those pipeline issues when you have such traumatic kind of events? The pipeline takes a little bit longer. Do you have that time, and are you thinking about in between?
So it's challenging. One of the most challenging aspects of this response has been the duration, right? So you expect to go through emergency responses in working in health and human services. That's part of the job. I kind of fancied myself fairly good at it, having come from Texas and experienced things like Hurricane Harvey and mass shootings and things that required our agency to respond very quickly. Those are sprints. This is an ultra marathon. And so I do think we have to kind of unpack it in two separate spaces, and we're working really hard to augment our team, build expertise out. We don't have to do this alone. Folks often hear me say our health and human services is a team sport, and we have some really active players out there who can assist us in this resilience work and really make sure that we carve out that dedicated focus while we work on this more strategic pipeline work as well.
Now, I'm curious, you've got two hats, and we can, make Texas jokes about the size of the hats, but
sure.
I'm curious, as you lead public health in a pandemic, you took over in a pandemic, and DHS, is that a deliberate move? What do you, or is it, all encompassing and overwhelming?
Yeah, well, perhaps both some days. It is deliberate. It is a deliberate move. It was an intentional move on the governor's part to ask me to serve in the dual role, because her focus really is on the better alignment between our two agencies. And as you just noted in my bio, this is not new to me. I worked on this effort in Texas, merging 5 agencies into one health and human services structure. And the goal of that work is to better align the units of the work at the state level to really support that front end delivery on the ground. And so that's part organizational theory and who reports to whom. It's also structuring of the way we pull down money from the federal level to better leverage what Iowans can access. And so this has been a year-long effort thus far. It will culminate into a new structure that is encompassing the broad array of those front-end preventative services, those true public health functions, all the way over into our Medicaid program and our state-operated facilities that are directly delivering care.
Okay. Kind of currently, Merck this week has asked U.S. regulators to authorize the pill for treating COVID-19. And while that, decision may still be a few weeks away, it would seem like having a treatment in the form of a pill and a prevention option could help in controlling the pandemic. I'm curious if you've had discussions yet about where you see that fitting in, and how big of a part of the plan is it?
Yeah. So, let's just pause for a second and remark at how incredible, with lightning speed, the scientists working on these evolutionary drugs have moved, while not missing a step in all of the normal protocols to make sure that these treatments are safe and effective. It's a phenomenal and heroic effort that we should be tremendously proud of as a society. So this is another tool in the toolbox. We started this pandemic without any, really. And our tools were to stay home in isolation, which was very difficult and continues to be challenging in some spaces. And today we have a vaccine. In fact, we have multiple options. And we're about to have children ready to access that vaccine. That will continue to be our number one tool in our toolbox. But drugs like this are, evolutionary, and we're excited to have another tool that will always be learning more about this virus and how to treat it is exciting. And we stand ready to assist providers in accessing so that Iowans can have the best care available to them.
I'm curious, when you talk about the public health offices in many Iowa counties, they're very small, and they're certainly not meant to build or to work around the clock like we've seen them doing throughout the pandemic. I'm curious if you see these roles changing, and how you even start to org plan some of these things. Obviously, that's going to be done in partnership with counties, but
Sure.
How do you see the public health roles evolving in Iowa counties going forward?
Yeah. So we have beyond stress tested our system, and those smaller, more rural local public health authorities that do sometimes just have one person who's, responsible for administering vaccines and doing all of the case investigation and administrative work encompassing a public health function. It is nothing short of heroic, truly. They have been phenomenal partners. And meanwhile, they're experiencing the pandemic themselves, right? So they're going to the grocery store and interacting with their neighbors who are scared and concerned, who may have lost loved ones. And so it has been, they have not had separation between their work and their personal life during this event. And I think that's been incredibly challenging. As we think about moving forward and our lessons learned here, we will absolutely, at the department level, be looking at the way we support their office structure and funding and having those conversations with county officials about how to better support preparedness when we go through another iteration of a response like this. And I think, this, as I mentioned before, this response is different than what we saw with Ebola or other pandemic responses in the past. And so I think that look back, which we are doing, we are obligated to do, and have been really thinking about how to best prepare. It will be assessing that structure, but that will come in due time. Those folks are still very much in an emergency response, and so are we. So there's more work to come there.
Do you see the scale of the size of this pandemic when you say that it's different than Ebola, and it's the size and the number of people that it impacted? I mean, is that what makes it different?
Yes, and the duration of time. There's no zero in this game. I think folks from the beginning have been looking for, like Ebola. Your goal with Ebola is to get to zero, right? You can quarantine and isolate your way out of that disease spread. And with this particular disease, you cannot. There was not an availability for us as a nation, as a global community, to get to zero here. And so our ability to continue to balance those precautions is incredibly important, and it continues to evolve as we learn more about the virus. And we, like you just mentioned, have more tools in our toolkit to treating the virus.
I have a audience question that I wanted to get in because I think it's relevant to the multiple hats. And would state government services for aging Iowans be more effective and efficient if the Department of Aging became part of the Department of Human Services? It's
Director Miller somewhere in here. I think that is something we are absolutely assessing, and of course, with Director Miller at the table. So yes, I mean, we provide aging services today. We were responsive for protective services for our dependent adults, and thinking about how we can better protect just aging adults in the state. We work really closely with ARP, so we are already a player at the table. But of course, there is an assessment that will come in due time with about what role our HHS structure plays in the support of aging services. Okay, back on other questions that I had. The need for real-time data in this pandemic has been unlike many, and there's been some criticism about the amount and the frequency of what it's been released. How do you plan to go back and look at that? And is that part of the review that you'll do of how policies to this point in terms of data that's available gets released? Mm-hmm. It already has been part of our review. This has been one of the key challenges in our response. We wanted very much from the beginning of the response, and of course, at the very beginning, I was just in the DHS director role, but still using those data points every day for our client service delivery. And what I can tell you is our data systems were not set up to do anything in real time. And you have to remember that this has been an incredible pain point, and Iowans the world has really seen us struggle with some of this. And this is really because at a local level, whether that be in a hospital, a nursing facility, or a local public health administrator, individuals, Iowans, are hand entering information that then funnels up to our data system. And that data doesn't always come in a clean way. So we have a team of people who are constantly checking the data, fixing errors. And then sometimes people just make mistakes. Nursing facility team members might enter positives when they meant to enter negatives, or vice versa. And what happened in this is people watched that unfold in real time in a way that we don't do in any other space. And so what do we do to fix that moving forward? We enhance our data systems so that these are electronic feeds instead of hand entering and hand fixing, which has been an incredible task and one that has really, in some spaces, shown stress in a way that we would never want to see again. That work is actively happening, and it will happen in partnership with our local public health administrators. Our ability as a state to really use some of these infusion of federal dollars to assist us in building platforms that will not buckle under the pressure of something like this is our goal.
Okay, I wanted to switch gears a little bit and talk about some of the concerns on the DHS side. Early on in the pandemic, we were hearing concerns about unreported child abuse or concerns about the levels. And I'm curious, what have those numbers looked like? Is, some of the operations have returned back to normal or closer to normal, I guess. And what do the workloads look like? And how are you handling kind of the caseloads, but also just the turnover and the retention of staff at DHS?
So from the very beginning of the pandemic, especially in the decision around closing schools, I was tremendously concerned about the impact that would have on our most vulnerable kids in Iowa, whether it's a child who can't be safe at home or a child who doesn't eat at home or both. School plays a vital role in making sure that we have eyes on children and supports in place for children in need. So we have a dashboard on our DHS website that has shown caseload over time, and we saw a dramatic dip about a year ago, in the kind of thick of the pandemic. Those numbers have returned to normal as school has reopened and been in effect this last year. We have our mandatory reporters back in line, but we can still see some dips in places where children are not going to well visits in quite the same way. And so there are other people that are mandatory reporters, like doctors, nurses, et cetera, who play a really vital role in reporting. In terms of the gravity of the outcomes, I will tell you, they're tragic. They are not necessarily higher in volume, but in terms of severity, places where the mandatory reporter system missed kids because they were invisible. There is a high price that we have paid in that respect. And so our goal, when we think about things like telehealth, it's amazing, right? It provides access in a different way. But what I'm really trying to steward is a conversation where we hold on to those best practices, but really do think about getting kids, youth back into a space, because you really can't sometimes mimic having a physical assessment in person in the same way you can in a virtual way. And the totality of the system has missed some kids in ways that really could have been prevented. We're also working as an agency to make sure we're doing that deep dive assessment across the systems too, working closely with hospitals, and partnerships with other players in that mandatory reporter space to do real-time action reports, critical incident reports, and shore up those spaces as close to real-time as possible. So I think it is a high consequence, as I said, but the system is responding so that we can prevent this in the future.
Had the mandatory reporter system ever seen something like this? That's almost a shutdown of that as well.
Not again, this gets back to duration, right? So perhaps in emergency responses where like full systems go down, like the floods or the derecho, for example, but that's short and then it comes back online. This is prolonged. And so we will be dealing with this as a health and human services system, the fallout, right? The increase in acuity in behavioral health, the breakdown of supports for individuals with special needs and child welfare cases for a long time. We will be able to see it in our data, I believe, for a decade or longer.
Now, switching gears again, and this is a fast moving conversation because there are so many topics. I'm curious, next year's the first phased in switch of the mental health services, and there's been the ask for the $70 million from the general fund to cover the cost of shifting mental health services away from property taxes. Mm-hmm. But that's kind of the background system. I'm curious if you imagine, we're at July 2023, and the system's completely funded by state dollars. Will Iowans be able to tell a difference in how services are delivered, and what will that system look like in your mind?
So the goal of the system should always be that Iowans can't tell the difference because they should be able to access the same services in all parts of the state. And that's going to be the goal of that state-funded system. I'd also like to mention that we're one of the last states to come into this kind of model, right, in the way that mental health services are funded. So it provides a level of stability and a level of oversight through performance-based contracts that allow us to ensure that consistency across all of Iowa. The second part is, and something that we are already seeing in a way that is wonderful, truly wonderful, is real innovation. So they're performance-based contracts, right? There will be money set aside to incubate concepts that really do move the totality of our system forward. And we are already seeing that today. We're seeing regions collaborate in a way we didn't see before. We're seeing real strategic planning in a way that we have not seen in the system before. And at the same time that we're doing this work, we are doing a full-scale assessment, really driven out of the Medicaid team, but in partnership with our MHGS regions, because these two systems have to fit together to really understand places where we have gaps in access to care for all of our long-term services and supports, but really focused on behavioral health. That's also happening at the same time that we're thinking about these agencies coming into an HHS structure. So really pairing substance use treatment with mental health services is happening at the same time too. So it's a lot of deep work, but yes, I do think that Iowans will see a difference. I think, shoring up those access points, when I hear families struggling to get their children into care, we never want that to happen. And so all of this work will take some time, but we will be shoring up those fissures in our system. And I do think a difference will be seen.
I'm curious, what do you see as kind of the next steps in the children's mental health system? Is that, moving in sync with this, or, I think funding is a major question for that. And
sure.
Where does that start to work in?
Sure, it absolutely does. So children are just one subset of a very important subset of this overall assessment of the system. And I think when we think about children's services, remember that the majority of children in Iowa receive services for behavioral health from Medicaid. So we've got a lot of money in the system. We're doing a full-scale assessment of rates in Medicaid, different than the agency has ever done before. There are spaces where the legislature tells us to look at rates, but we're doing this in a different way, in a more predictable, routine way that I think will really advance our payment structure. Meanwhile, we're working on the things I just mentioned, right? Thinking about, do we have the right sets of services in the right places in the states at the right level of care so that Iowans can access services where in their home, because we know keeping kids closest to home is best. And the last part of that is building the provider base, right? So that is bigger than just IDPH or DHS, it's bigger than HHS, but thinking about how we build clinicians. So everything from psychiatrists to our mid-level providers, we recruit them, we grow them in Iowa or recruit them from other states and keep them here is part of a more full-scale statewide assessment that I am very much seated at the table to collaborate on. And so again, that's a space where I think the legislature, led by the governor, will have a really important conversation during session about how best to do that as a state. And it'll be an overall strategy. Behavioral health, we need more providers in this state.
So I'm curious, we're at a point in time where you also have funding in the form of the ARPA funding and the COVID recovery dollars. Mm-hmm. I'm curious, where what do you plan to use those for? And how, are they being used in some of the streamlining work that's going on within the department?
Yeah, gracious. We have a lot of COVID dollars right now between our two agencies. So we are really thinking strategically about how best to use these dollars. In some spaces, we have like childcare, for example, Zack, we have made direct payments to provider, kind of shore up the system in an immediate need, right? Kind of stop the bleeding. But in the totality of the way that we're thinking about spending our dollars, we're thinking really strategically. Lessons learned from the pandemic pandemic? Where do we have big gaps in the system, and how do we use this money to shore up that gap beyond just a COVID response, right? This is driven by COVID, but we have a lot of work to do, I think, that can be foundational in nature. So those are IT investments, really significant IT investments that are coming in IDPH, as I mentioned, that will shore up some of these data challenges that we have seen in a fairly painful way. It also will come in building out provider networks and a full-scale assessment of our behavioral health services in the state, and an assessment of our services and supports for individuals with intellectual and developmental disabilities. That's coming through enhanced dollars in our Medicaid program, but also ARPA funds, right? Same thing on the childcare side of things. The governor convened a childcare task force. Those recommendations will be coming out very soon. And in those recommendations, you'll see a strategy that starts to shore up some of the issues in childcare in this state, a state that has more two-parent working households than any other state. The pain points that existed before the pandemic, but were absolutely exacerbated by the pandemic. And so I think there's really, really smart investment work that is happening here that will change our system. So we're trying to be incredibly good stewards, take a ton of input from our stakeholders along the way, a lot of listening sessions, and all of this is laid out on our, primarily on our DHS website, where you can join some of these discussions. We want to hear from Iowans who have lived experience about how to shore up these spaces, these gaps in our system. And we've got a really phenomenal amount of money to do that work. It is something that I think no HHS director has ever said before, right? This is a gift. We have money in the system to do things that I've worked the entirety of my professional career and only dreamt of doing. We also have the right people in the right chairs to do the work, and a whole lot of really active stakeholders to help us along the way.
Excellent. I have another audience question that I wanted to get to, and it's a friendly one. So
okay, that's fine.
Speaking of your work to build a better system for Iowa's aging population, thank you for the new local adult protective workers and for your recent application for federal dollars to increase home and community-based long-term care supports. Yeah. Can you speak to how these and other pieces are part of your department's vision for what's next?
Oh my goodness, absolutely. That's a great question. I will tell you, that our focus on adult protective services is something we did during COVID. I mean, I think you can see why, right? Our older Iowans really struggled in isolation. Our dependent adult Iowans were incredibly vulnerable during the pandemic. And so Iowa's strategy around that is a long time coming. I just was able to sit in the chair that helped advance that effort. And we have a strategic plan around that effort to really elevate protective services. We've been working with the AG's office in close collaboration, county attorneys, and our friends at the Department of Aging and ARP. And a number of other key stakeholders, Leading Age, et cetera, who really have helped us craft this. Aging has to be part of this vision in our agency. It needs to be for our nation. We have a whole generation sitting just ahead of me that is going to need that care. And our goal as an agency is to ensure that Iowans can safely age in place with their services available to them. And so that HCBS plan is squarely focused on that, along with a number of other goals. But that's a really phenomenal question. And I look forward to having more dialogue during the session about what that real vision looks like.
The last question that I have on my list, and it times perfectly, is the state's new Medicaid director said recently she thought the state's managed care system was stable. And I'm curious if you agree with that assessment, and what types of measures do you have that support that status?
Yeah, absolutely. So I do think it's stable. The state has made a tremendous investment to make sure that the rates are there to support the work. We can see it in outcomes now in a different way. These things, healthcare has a long tail, so it takes some time to mature. We also have two really committed MCOs in our state. They have made phenomenal investments in their responses. You can see this like in their derecho response and delivering meals and supports. You can see it in their COVID response and what they've done with vaccines. We are in a procurement stage right now. So our AmeriGroup contract is in close to its end of life cycle. So you will see us as an agency procuring that. We are obligated to do that by law. And this will show, I think, you've seen probably publicly that there are some companies that have indicated they have some interest And I can't talk about it too much, right? And I have not had conversations with those companies, but even just the idea that they're showing interest in wanting to come into our state shows the work that we've done. We've also done a really tremendous amount of work in making sure that the state side of our Medicaid team has the right number of people, skill sets, and depth of experience to support a strong managed care oversight. That is a huge goal of mine. So the state runs this effort, right? And we are in the driver's seat. And so I think DHS also has a renewed commitment to that oversight. And so when Director Matney speaks to that end, it is with real vision around how we drive success in this more mature state.
Well, excellent. Director Garcia, I appreciate the candor. I appreciate the taking of the rapid fire questions and for the work that you're doing. I know it's been a difficult span, but appreciate that. So on behalf of the team, thank you. And to our attendees, on behalf of Iowa Ideas, next up, I'm going to run downstairs and get ready for our next conversation with Iowa Governor Kim Reynolds. I haven't seen if she's pulled up yet, but we expect that to begin at 1:15. And so we'll take a quick break and see you soon. Thank you.
Thank you, Zach. That was great.
Thank you.
Appreciate it.
Thank you. Appreciate it.
Bye-bye.